Welcome to Catalyst for Healing. I am Maria Lloyd, licensed marriage and family therapist, and I am here today with Dr. Richter.
Nice to have you.
And
Thank you so much.
we're
Thanks
so
for having me,
excited to have you back. Definitely missed having you on the podcast. And
miss it too.
I know. So we're going to talk a little bit today because we realized one thing we hadn't covered before was talking about the neuroscience and having a doctor, be the one to talk about that is appropriate because there's a lot that goes into the actual brain benefits of using ketamine to treat mental health.
Right. Yeah.
So,
and I feel like it's still a very new field that's being explored. So
yes.
There's a lot of literature out there, yes, but also just like with everything, it takes some digging to filter what we know, what's modeled now on animal studies and what we've observed. So there's a couple of things that we definitely know.
Okay.
We know that ketamine certainly has antidepressive effects, and the modality is different from your typical antidepressants, and that's where I would kind of go into it, try to actually compare them the different way they actually work.
Okay.
So your typical antidepressant that was really invented like in the 90s and heavily used in the 90s and to nowadays, your typical antidepressants work in a way that they affect directly the neurotransmitters that we know to some extent are involved in mood regulation and mood in general. And those namely, and most people colloquially will even know them, serotonin, dopamine, people talk about those all the time. So, and norepinephrine to some extent. Mm-hmm. And so to some extent, we focused on upregulating or allowing to some extent upregulation of these neurotransmitters to provide in a way more of the neurotransmitter, the substance for the brain to reap the benefits in a way of more of the, in a way, like positive thinking and more constructive thinking and all of these, directly kind of acting on those neurotransmitters.
That's how the SSRIs work. Okay.
So SSRIs, they work on the serotonergic pathways, right? It's selective serotonin reuptake inhibitor. So it just, and whatever you look at, whether it's SNRIs, it's serotonin and norepinephrine, right? Yeah. And they are involved in dopaminergic pathways through the serotonin and norepinephrine. They all kind of work as to almost stimulate those neurotransmitters. Yeah. I think we're all realizing that that might not be the only way to go. Yeah. As we're now, facing the crisis where people are bouncing from one antidepressant to another and a sprinkle antipsychotic on it a little bit for mood stabilization because that has some dopaminergic pathways.
And we're finding more with the gut too.
Oh, so the side effect profiles. Yeah. So the side effect profile is a whole different story, right?
Yes.
But we're realizing that in long-term healing, that might not, first of all, not be the only pathway. Yeah. But also it really might work only for a minority of patients. And so the data that came out with...
Oh, I'm curious. What is the data
the data that came out with, for example, with Spravato, that, again, that's just a data point on a clinical trial that was about 10 years ago.
And that's ketamine in the nasal spray form.
Yeah, it's just a different form of ketamine with essentially the same benefits.
Right.
Let's call it what it is.
Yeah.
And the study started to show that if you fail, and about 30 to 35% of patients will get benefit with antidepressants with congruent therapy or without.
It's only 30 to 30?
35%. They will go into second line of antidepressants, so there might be another about 25 to 30% benefit.
That is lower
but
than I thought.
if you fail those two, you have about a chance of 10% that you will reap any benefits from any added antidepressant or a switch to antidepressant. So I think it's showing us that in general the classes, regardless of what side effects you had, if they're not helping you, it's diminishing returns. They're unlikely to help you no matter how many times we switch you.
Wow.
It's very unlikely that they'll help you. That's the general idea behind the study. So that's where, the whole movement of psychedelic-assisted psychotherapy came in. And we've noticed that this medication, ketamine, works in a different way.
Yes.
It has effect on these neurotransmitters, but through a different pathway. Okay. So ketamine has been around for a long time. We've talked about it on the podcast since the 70s, basically. Yeah. Mm-hmm. We've noticed that it has effect on glutaminergic pathways. Yeah. So glutamate being, in general in brain kind of the excitatory neurotransmitter, and it acts on what we call an NMDA receptor, not to be mistaken with MDMA receptor. But
right.
There's no such thing. But the NMDA receptor, the glutaminergic pathway, has some to do with mood regulation, memory formation, higher cognitive thinking. It's involved in a lot of pathways.
And it increases the glutamate.
So glutamate,
right?
so actually, in a way, glutamate is the most abundant neurotransmitter in the brain, right?
Oh, okay.
And it acts on so many different parts of the brain. And ketamine actually binds to an NMDA receptor, but antagonistically. And in some ways, it has a reciprocal reaction to actually enhance activity of the glutamate, more glutamate in some areas, especially of the brain. And the areas that we also found are more of the higher thinking areas, prefrontal cortex, that also have to do with memory formation and kind of constructive thinking. It has to do with mood regulation also, but it seems to enhance that glutamate, basically, through antagonizing the NMDA receptor, and produce and allow for more glutamate actually in the brain, also in specific parts of the brain.
Okay.
And we started to observe that in a short term, and there are studies that support that right now. There's some mice studies and there's some observational fMRI studies that have showed that in a short term, and oftentimes we see that in a short term, that glutamate upregulation through the ketamine antagonizing NMDA receptor pathway, it actually short term, in about, we are seeing it anywhere from like 6 to 8 to 24 hours, has a pretty quick antidepressant effects.
Yeah.
They're more short-lived, but they're in a way a bridge. So we've observed that there are some antidepressant effects directly through the glutamate.
Okay.
But this enhanced production in a way of glutamate in the brain through the ketamine pathway also seems to upregulate another peptide, another protein, it's not per se the typical neurotransmitter, but it's got a fancy name, brain-derived neurotrophic peptide, basically. It's
the BDNF.
The BDNF. It seems to have to do with more, in a way, formation of synapses, the interconnections between neurons. And from my studies now, we know.
And that's when they're talking about the neuroplasticity.
Exactly.
Okay, the BDNF
and
is connected
so
to that.
We are starting to postulate that ketamine upregulates the glutamate in a way. And the short-term effect has some antidepressant effects.
Yeah.
And the long-term effects that transition into a more long-term profound antidepressant effect. Okay. And all the other downstream effects that we're seeing is through the neuroplasticity. And that's upregulates the BDNF. And what happens then is there are my studies that show increased production of synapses and dendrites, also specifically in the parts of the brain that we just talked about, that have to do with mood regulation and potentially cognition. And so a lot of the anhedonia and dysregulation, all of that can actually be, in a way, enhanced through that pathway. Yeah. So that's, in general,
and then it also lowers the DMN, right?
So
default mode network.
Right. So in that way, it also downregulates those.
Yes.
And it can enhance kind of the repairability and, in general, the underlying as if mood, basically.
Okay.
So in a way, it seems to have this more of a long-term effect.
And it's not dealing with serotonin at all.
So it will affect it inherently because all of these, and it's one thing to keep in mind that all of these neurotransmitters act in synchrony. That this is all a meshwork of everything.
Yeah.
But it directly doesn't act on them, right? Like the typical antidepressants and some more atypical antipsychotics that have to do more with dopaminergic pathways.
Yeah.
It seems to be working more through the glutamine pathways and then affect more of the neuroplasticity.
Yes.
That's where actually we're observing on some studies that are coming out that it might be even more enhanced with the directed therapy along with the ketamine treatments, because it seems to actually make the changes more long-lasting.
Exactly.
That are the neuroplastic changes enhanced by the ketamine and the glutamatergic pathways. So in a nutshell, I would say that's kind of the chemistry as to how ketamine works, and how do
you compare the effectiveness? So you just said 30%
effective
with antidepressants, which I haven't heard that number, but what are you seeing in the research with ketamine?
And what I'm saying is there might be more patients that if they switch the antidepressant, they will get relief as well. But the thing is, it's diminishing returns.
Yes.
What I'm saying is if you failed a first line or one antidepressant, you're not even equally, but less so than to benefit from another one. You might still find benefit, but overall the category hinders somewhere on 50% range or
Wow.
so, 50 to 60% range.
Yeah.
So it's a huge amount of people that not only will not get much of a relief, but there is not much left for them. And that's where we come in. Right? That's what we're left with, because so far most of the classes that we deal with either have to do with direct serotonergic, norepinephrine, or dopamine pathways. There really hasn't been another medication like ketamine that works differently, right?
Well, and I mean, we're also comparing, again, the trial and error process can take a long time with any medication.
And you see that.
But also the 2-week waiting period. So like, let's say, I mean, that's what I found so exciting about ketamine was I might have a suicidal patient come in and you tell them to wait for 2 weeks. I mean, that's a long time when you're thinking about harming yourself.
Yep, definitely.
And ketamine is like really immediate.
Yes.
If you're doing the IV. I mean, again, like the IV might not take effect till the 3rd. I mean, what are we seeing with that?
Oh, it's really individual. I would say yes. I would say and it really is individual how quickly people may have breakthroughs.
Yeah.
But I would say if you're really severe, you might actually see the effects faster in a way than if you're not as severe. Regardless, the effects are there. So sometimes we're seeing it around 2/3 session that people tend to have more breakthroughs.
Yeah.
But I do see the effects.
So with Spravato, it's closer to like the 6th.
Yeah, I would say with Spravato, it's at minimum halfway through the treatment course, which if you get approved for Spravato, it's technically 12 treatments total.
Yeah.
But the first 8 are in the first 4 weeks, and then you spread it out. One per week or one every other week. So then.
And unfortunately with Spravato, because your clinic just added it so that you could have people that cover insurance.
Ultimately,
They have to try and fail 2 antidepressants first, right?
Yeah. And
to qualify.
And I would say this about it. I mean, a trial and fail antidepressant, a lot of the antidepressant will have side effects that's a failure in itself.
Yes.
And I'm not saying that you should disregard alternatives just because you had a bad side effect to one, but it definitely doesn't mean that for you to fail, you have to be on it forever in order to realize whether you're really failing it or not.
Yeah. I just wish that restriction wasn't in place because
Fair. No,
you don't have to say anything.
I don't make the rules.
I know.
Yeah. We try to help people with
but wouldn't that be a better first line of treatment to start with ketamine?
I definitely
in my opinion.
And I think we're going to more and more. I feel like move to like this interventional also therapeutic component, which when it comes to interventions, we always had kind of the paradigm of the outpatient, the slow burn, kind of the clinic, the antidepressant, because like we just talked, we don't have anything else out there.
I know.
We don't have another modality, another medication that would work differently than from the ones that we just mentioned, which is the antidepressants and the atypical antipsychotic, which gets sprinkled on everything because we just don't have anything else. Yeah. PMDs and psychiatrists don't really have anything else, right?
I know. And unfortunately, I keep seeing with the psychiatrists, I mean, not to generalize, but a patient of mine might not be getting better on the antidepressant. Instead of switching antidepressants, they're adding more and more things. And I'm seeing the antipsychotics being used way more than they should be.
Because there's nothing else. Because there's nothing else, Maria. I swear to God, like as a physician, you want to be doing
so frustrating.
something.
I know.
And sometimes nothing is worth doing.
Yeah.
And less is more in that sense sometimes.
Right.
But we have nothing. We haven't had anything else.
Yeah.
And so psychiatrists are not trained in therapy really by the medical training residents.
Correct.
It's mainly pharmacology, right?
Yeah.
And in that sense, I feel like you try to provide help, but you have such limited repertoire of things that
really
you know work very similarly, that you're just grasping for straws and you're just adding things because you don't know what else you could do, right?
Yeah.
And so the therapeutic component is huge. I would definitely speak to that. But the intervention, now we have something else that works differently, right?
And I want people to know, take your time and find a good psychiatrist because it really makes a difference who you have. And I mean, I've had to really get upset with certain psychiatrists because I'm like, don't keep adding something like we're working on this intervention and therapy. Why don't we give it some time? Because once people are on multiple medications, me being an example of that, just kept adding more and more. Like it's really hard to get off of them. And the side effects are awful.
So that's the thing where I don't think I'm not going to lie because I haven't read the basis of a lot of the clinical trials for the antidepressants, but majority of the time you have to show safety and benefit, right?
Yes.
That's basically the purpose of a clinical trial, right?
Yeah.
But no one's really asking you what it is to taper off or wean off a medication, right?
No.
That I don't believe. I mean,
And
maybe
it's
phase
a
4,
nightmare.
but it's not something that goes into FDA regulation, I think, very commonly. And so that's where we're ending up with, okay, the medications might be working for some people, but God forbid you try to get off of them because we haven't really studied that. And
we know
seeing in a population
that people
now,
are having a very hard time because...
And we're seeing it now in a population now because there's more and more people are realizing, look, I don't want to take medications that don't really work for me all the time.
Yeah.
I don't want to keep adding things. So why don't I just get off the medications? And we're seeing the backlash of that now.
It's huge.
And it's individual again. For some people, it may be okay. For some people, it's almost an unthinkable. Yeah. I mean, I've had patients that literally told me it was, and some of them had other syndromes, but they've said it was worse than getting off some opioid medications.
Oh yeah, it's so destabilizing.
So it's
for
it's
when I've walked through that
it can be extremely difficult, and it's something that we haven't really, I think, researched very much.
Yeah.
Okay,
well, getting back to percentage of people that get better with the ketamine. So in comparison, let's say.
Right. So that's what I would say.
I mean, I know it's showing like 80%, but what is it really that you're seeing at the clinic, and what?
What I would say is, we're seeing patients, especially that have trialed other antidepressants and failed. Then they're in that group of still a massive amount of people. You're talking easily, 40% of the patients.
Right.
That can truly benefit, and it's up to 80% of getting control of their symptoms, basically, right? And that's massive. And the other problem is always basically being in remission, staying in remission with what you're doing, right? So that's where I would say that's something that I feel like the benefit of ketamine can be the new way, in a way, of the neuroplasticity.
Yeah.
Because we're seeing more and more with sometimes requiring boosters, but they can be well spread out. Yeah. They can be weekly or even every other week. We're seeing more and more that the first uptick of being able to help with symptomology of about, let's say up to 80% of the patients that have failed a lot of things already.
Incredible.
Then with appropriate booster and therapy, we can keep, majority of those patients, still 50 or 60% of those patients in remission out of that, which is another huge number that I would want people to know. Yeah. Because that's something that we oftentimes struggle with, right? Yes. You get hold of symptoms for a little bit, something happens, and you're back where you were. We don't quite see it in as robust numbers with what we know about the ketamine treatments and the therapy directly.
Now, is there statistics? Because one of the problems we have in the U.S. is that ketamine clinics opening, right? They're not helping to provide the integration with, you guys require therapy. Right. You really understand how important that is. Right. I'm curious what the numbers are for those that don't do the therapy versus those that do.
The Spravato, when Johnson & Johnson came up with Spravato, the clinical trial that it was modeled on, technically didn't have therapy component. Really? So in that sense, they showed still very good numbers.
But what's the long term?
Long term, the remission was, I think, I don't want to lie, but I think close to up to 50% with booster series, because they have a booster series built in. Okay. So the first induction being, let's say, 12 treatments, I would say and as far as I know, there's no clear head-to-head comparison between Spravato and IV. But as of right now, from what we know and observation, I would still say IV, and it makes sense. It's still, in a way, the gold standard. Yeah. It's still, I would say, the modality that works the best in general. But, of course, it's not covered by insurance most of the time. You might get some reimbursement later on, but it's not upfront. Yeah. And so the Spravato model that they did in the clinical trial with the booster series after the initial 12 treatments still kept, I want to say, 30 or 40% of patients in remission. Which is still amazing without therapy. And we need more studies when it comes to therapy, because from observation and from other clinics reporting also, and our providers, we know the therapeutic component adds quite a bit. Adds a lot. It's essential in a way. Yeah. We all know that. We just don't have raw numbers to compare it to specifically what they came up with without the therapeutic component, which is Spravato. So I think it's a good model to work with, but you can guarantee that if you have directed therapy, you can certainly maximize the benefit and keep many more patients in remission.
Yes, yes. Okay.
That's me trying not to speak about numbers that
No. Yeah. I know. I appreciate it. Well, I think we covered the brain benefits. I mean, I know there's more that we could go over, but you did a good job of highlighting the neuroscience around it, but then also the statistics. I guess my encouragement to people is, obviously consider this route before going on medication, because I have been in the medication system. And there's two reasons why I would discourage it. One is this thing we're talking about where I was on one and then I added another and then there was another added. I was on 3 heavy meds, 2 of them antipsychotics for over 20 years with really horrendous side effects. And I'm still getting off the last of them because, like you said, the tapering process is horrendous. Yeah. And they never really worked that well. Like, that's the thing. It's like, it'd be one thing if they worked really well. That's different. But in my opinion, and this was my reason I got passionate about ketamine, was ketamine got me like that spark of life back and the energy back that I didn't have, but got me at understanding the source of my depression. And, these other, the medication it's helping you manage the symptoms, but you don't really get to the source of the trauma or whatever it is that's keeping you depressed. Because yes, I mean, there is some genetic component that some people get more depressed than others, but environment makes such a huge difference in how the genes are manifested. So 100%. Anyway, that's why I get all excited about this, because it helped me so much, and I want to save people from getting trapped in the medication system that may not be necessary at all. And Absolutely. This is so much more effective.
And now we have protocols finally with this medication that works and is safe. Yes. That's why I would encourage people. Yes, be aware about medications being prescribed like candy by company pharmacy, taking it home. But now we have a clear FDA-approved product.
Yes.
And not only that, if you find, and that takes some digging, it takes some research to find a clinic that does it more in a responsible manner, right? Yeah. But if you can find that, and obviously we've talked about it before, what differentiates other clinics from other providers, if you can find that, it's truly a safe and extremely efficient
first-line treatment.
Absolutely.
Yeah,
it's an
absolutely.
Yeah.
All right. Well, thanks for joining us, as always. And we will see you next week. Catalyst for Healing. Bye.
Take care.